welcome to the Orthopedic Tutor YouTube channel. Today we are going to discuss further on regarding the tumor basics, part 2, about the classification of tumor. How well do you know a tumor? Are you able to differentiate about staging and grading? I will answer that in a very short moment. We'll see that in order to deal with a tumor, you need to know about the characteristics of the tumor itself and also how bad is the tumor going on inside your body. So in order to know all those information, there are two basic types of classification of tumor, which is called the staging and the grading. Well, let's talk about the grading first. Grading is based on the histological features of the tumor. So you cannot grade a tumor unless you have performed a biopsy of the tumor and you have found out about the histological features of the tumor itself. Well, about the grade of the soft tissue sarcoma, usually a pathologist will look at the tissue sample from the tumor under a microscope, and there are factors that are used to determine the grades of the soft tissue sarcoma, including how often the cells are dividing, number of dead cells or tissues that are present, the number and kinds of cells in a tissue sample, the size and shape of cells and their nuclei, and also the type of the cancer based on histology and how different the cells look from normal cells or the differentiation level. And based on all those information, then the tumor can be graded. Now there are various types of grading system out there. They are called the WHO system, which is based on the degree of cellular differentiation, and you might see it sometimes in a histopathological report mentioning that the tumor is poorly differentiated, moderately differentiated, or well differentiated, and these are all based on the basic characteristics that the tumor cells presents, such as the presence of an immature cells, the level of keratinization, and so on. Now, moving on to other grading systems by the Broder. So Broder grading system is based on the level of cellular differentiation. So in a tumor, it is known that in a higher grade tumor, or let's say, in other words, in a more severe case, usually the cells are even more undifferentiated. So when you have a tumor that is clearly differentiated, you can recognize the type of cells, you can know which lineage of the cells is going on to, then the tumor usually is in a better grade, in a better condition, or in grade 1 compared to those with totally undifferentiated ones. They are considered as a grade 4. And then the other classification that are less commonly used are such as the Bryans Classification. For the Bryans Classification, they differentiate it based on these factors, 4 factors, which is the degree of keratinization, the polymorphism of the nucleus, and the pattern of invasion, and also the response by the host. Now, each features have their own value, their own numbers here you can see, and you need to match each of these characteristics to these numbers, and you might need to sum up all of these numbers to be able to classify the tumor. The last one would be the classification of soft tissue sarcoma. For those of you who haven't read about sarcoma, basically when a tumor comes from a epithelial cell line, we call that a carcinoma. Well, those that comes from the mesenchymal cell lines, we call them as sarcoma. Well, the tumor itself, for the sarcoma, The most commonly used one for these are the FNC-LCC grading system. The FNC-LCC grading system grades the tumor once again using a numeric score based on three factors, which is the tumor differentiation, mitotic count, and tumor necrosis. And with these each score, when it is all summed up with total score of 2 or 3, the tumor can be determined as a low grade. With a total score of 4 or 5, the tumor can be determined as intermediate grade, and those with higher scores are said to be in a high grade. And these are all used for grading. Now, let's take a look about staging. Staging is a little bit unique because it does not only include grading, it includes even more further and complex evaluation of the tumor. Let's take a look first at the benign one. The benign classification system, the benign musculoskeletal tumors classification system are usually described using the Anakin Classification. Anakin is a very prominent figure in this musculoskeletal oncology. It's best if you look for his original papers and read about them. Anakin has mentioned that in a benign case, the tumor can be divided into latent, active, or aggressive based on the description of the borders, whether it is a well-demarcated borders, it has an indistinct border, or unclear borders, such as in aggressive cases. Well, that is the only classification that is commonly used for benign. In malignant cases, the Anakin classification has been revised several times. So the Anakin, during its early years, it is developed before there is any advent of imaging system, and it is initially evaluated and endorsed by the Musculoskeletal Tumor Society (MSTS), and later on taken by the American Joint Committee on Cancer. So Anakin's purposes include to incorporate significant factors that describes the progressive degrees of risk of recurrences and metastasis. They also stratify stages for surgical management and provide guidelines for any adjunctive therapy. So based on all these factors, Anakin classified them based from the first version. We'll talk about that first. From the MSTS version, he classified into 3 different types, with type 1A, 1B, 2A, 2B, and grade 3. For the stage, for the stage 1A and 1B, both have low grade. Remember the grade we just discussed about? This is where it is being put to use. For the A and B, it is determined by the extent of the tumor, whether it is an intracompartmental or extracompartmental tumor. The same goes for stage 2A and 2B. For stage 2A and 2B, the grading is high, and the local extent determines the A and B. And for the stage 3, the local extent and grading can be in any condition, but there is definitely a positive metastasis. Well, the definition of intra and extracompartmental can be read in his early papers. You need to determine what is the extent of one's compartment, because each body parts or body regions have their own natural barriers, and once those barriers are crossed, then the tumor is considered as extracompartmental. Next is the AJCC version. This is the version that is later on published. Initially, it is a lot like the ones first published under the MSTS, but there is a stage 4, while the stage 3 is still left undefined. The stage 4 itself is also subdivided into 4A or 4B, determined by the localization of the metastasis. For stage 4A, there is metastasis to the lymph node, and stage 4B, there is metastasis at a distant site. Later on, the AJCC version is then revised with three major revisions. The first is there is no longer the use of term intra and extraosseous in describing the tumor, and then the tumor with skipped metastasis or discontinuous disease in the same bone is now considered with stage 3. Discussion regarding the types of lesion around a bone, such as reactive lesion, skip lesion, can be seen in the next video. And then the stage 4 is subclassified based on the metastasis location. Now, this revision makes it clear what condition of tumor is defined as stage 3. Here we can see the summarization. We can see here that now the terminology is rather based on the size of the tumor rather than being unclear, such as the old statement of tumor confined within the context or intracompartmental. The statement has been changed into tumor with size 8 or less in greatest dimension, while for T2 the size increased more than 8 cm, and T3 is for skip metastasis, which is defined as the presence of discontinuous tumors in the primary bone site. This designation is a stage 3 tumor that was not previously defined during the initial revision. While the M1 lesion has been further subdivided into M1A and M1B, which mention that A represents lung metastasis and B represents distant metastasis. And in the stage grouping, the stage 4A is therefore M1A and stage 4B is M1B. You can notice that this system is a lot like the TMM system that is developed, and there's another table here, I'm sure, that describes the final classification. There you go. So for the final classification or stage grouping, it is based on the involvement, the size of the tumor, T1, T2, or T3, based on the description earlier, and it is also based on the N or the node and the metastasis state of the tumor, along with the grade. We can see here that the addition of node is noticeable, and the number of stages has now developed into stage 4A and 4B. So when looking back at the initial Anakin stages, we can see that this modification of it has been very comprehensive, and one can clearly define the level or the degree of the disease just based on these numerics. Well, for the final classification, we can see that low grade is conditions in stage 1, whether it is a 1A or 1B. Okay, and for the high grade, it is considered as a stage 2, whether it is in a 2A or 2B stage based on its size, and if there is any skip lesion, then automatically the lesion is considered as stage 3, and if there is metastasis, then it is a stage 4. 4A or 4B is determined by the site of the metastasis, whether it is in the lung or in other sites. Here is another description regarding the TMM system based on the AJCC final revision of the Anakin Classification. You can see here that the T1 is for tumors with size 8 cm or less, T2 is for tumor size 8 cm or more, and T3 is for discontinuous tumor. While for N, if there is any regional lymph node metastasis, then it is considered N1. So to summarize this, there's another one. For the distant metastasis, this is as mentioned before. As you can see here that the G1, 2, 3, 4, this is also based on one of the grading system I've mentioned earlier in this video, which is subdivided into a well-differentiated, moderate differentiated, poorly differentiated, or undifferentiated. Okay, to sum it up, you need to know about the histological features of a tumor to determine a grade. But in order to determine a stage of a tumor, the process is more complex and you will need more information. Especially remembering the T, N, M, and G system, you will need to know the size of the tumor, which could be determined radiologically. You could determine the involvement of the lymph node. You must also determine whether or not the lesion has metastasized and whether or not the grading of the tumor is in high or low grade. So it is not a weird thing for a doctor to know the actual stage of the patient, even sometimes after the surgery, because staging is very dynamic. You could receive a patient with initial stage 1 or stage 2 and later on suddenly switch their diagnosis to stage 4 after discovering a metastasis that is still asymptomatic in other body site. So staging is indeed a very flexible thing. Things could get worse as you discover new information regarding the patient. While for the grading, it's usually fixed because you obtain a tissue, you look at the tissue, and you know the grade of the tumor. The last topic I would like to include in this video is a brief explanation about spreading of the tumor. You need to know that the tumor is able to spread to a distant site because the tumor itself presents in several different theories, and one of the most popular theory that is being mentioned a lot in references and is a must to know in any exam is the Paget soil hypothesis or the Ewing circulation theory. For the Paget soil hypothesis, it is likened to a plant where there is a seed and there is a soil. For the seeds, they are malignant cells that are escaping from the tumor bed, and for the soils, it is the body tissues that are advantageous for tumor growth. So when a proper seed meets a proper soil, then tumor can grow, or the seed can grow into a huge plant, and that is the same as metastasis. That explains why certain types of tumor likes to metastasize in certain body areas. Next is the Ewing circulation theory. It has mentioned that metastasis depends principally on the routes of the tumor dissemination, such as the Batson's valvulus venous plexus that forms around the vertebrae. And this explains why certain tumors can metastasize in only certain specific locations. For the Batson valvulus venous plexus communicates with the pelvic and proximal halves of the upper and lower extremities. It may occur in a retrograde fashion from the sides of the primary tumor, and it will nest inside the vertebrae, explaining why metastatic bone disease is commonly seen in the vertebrae. And the next is the metastatic process to the bone. I have here a picture that is taken from a journal. This is a rather nice picture because it depicts in a very plain way of how the tumor may spread or metastasize. You see here that in point 1 that a primary malignant neoplasm is forming, followed by the new vessel formation and invasion of the tumor cells on the walls of the vessels, and then embolism occur. The tumor cells embolize and may be arrested in distal capillary site where the blood flow is sluggish, such as the proximal femur here. And then in here we could see that the cells are extravasating outside from the cell walls of the vascular system, and then in response to a proper microenvironment, the tumor shall proliferate at a distant site. So understanding this cycle makes you able to explain how does tumor spread from one tissue to the bone. Okay, that would be all for today's video. Be sure to log in and watch the last part of this basic oncology, or the oncology part 3 video that is available in the oncology playlist. Thank you, and don't forget to subscribe to my channel for more videos. See you.